Today, I'm going to be talking a little bit more about these issues of sexual assault, suicide, alcohol and other drugs, and the co-occurrence. And when Tom said, talk about something you're incredibly passionate about, my brain went in like a million different directions. But what I'm truly passionate about is the work that I get to do at Health and Wellness at the University of Washington, and the very intentional way that we've created this department to really address these co-occurring issues. So I hope to share that with you today. So on our agenda is we're going to spend a little bit of time just going through sort of the recent trends. I'm not going to get lost in the data in terms of what's going on, but I think it's incredibly important to situate ourselves with what are the current trends around these issues, what are we talking about when we talk about these issues, and then how do they co-occur, what are some of the ways that they overlap. Jason addressed that a little bit, we'll dive in just a little bit more. And then some of the education prevention strategies, and then show you sort of how we bring this all together into a comprehensive model to the best of our ability within health and wellness at the University of Washington. So with that, let's dive into current trends. The American College Health Association, it's an amazing survey that goes out every year across the nation, collecting data from college students. Over 30,000 students respond and talk about their health issues, everything from do they use seatbelts to what's getting in the way of their academic success. And college students, it's important data because it also helps us really understand some of the ways that these issues are overlapping and co-occurring. And we know that among the undergraduate students who reported drinking within the last year, they actually were reporting some concerning behaviors and consequences from these drinking. This is just a few that we pulled out. 33% did something that they later regretted while they were drinking. We have about 29% forgetting where they were or what they did, so essentially blacking out as a result of drinking. We have 13% physically injuring themselves. 4.4% of students are seriously considered suicide as a result of drinking or while they were drinking. And 2.8 had an experience of having sex without giving consent, so someone sexually assaulting them while they were drinking. So you can start to see why it's really important to sort of note the impacts that these issues can have on one another. Again, I don't want to belabor this too much, but we know when we talk about prevalence of heavy binge drinking, often definitely identified as an issue for our college populations, but also nationwide, a concern. We know that 26.9% of people 18 and older in 2015 reported that they engaged in binge drinking in the past month. And we have 7% reporting that they engaged in heavy alcohol use within the past month. So in addition to binge drinking on more than one occasion. So some pretty startling stats. So what's going on with mental health and suicide? We covered some of this yesterday, but just wanted to give us some perspective, particularly when we start talking about our youth and counseling center and college settings. We know that in 2017, it was the 8th year in a row that anxiety topped the list of health concerns for college students coming forward. And we know that 51% of students who visited counseling centers reported having anxiety, followed by depression, relationship concerns, and that they often endorsed multiple concerns. So they weren't just struggling with one of these issues, often they were co-occurring and compounding. Our youth are struggling. Some of our youth are very much hurting. 13 to 16, 1 in 5 children will have experienced a significant mental health problem during their educational experience. So if you think about youth struggling just to show up and engage in the academic setting and how distracting and disabling this can be. So our suicide rates, I'm sure some of you have seen the headlines. There's been some pretty concerning headlines. Suicide rates, unfortunately, are climbing for most populations. We know since 1999 they've been on the rise and have increased 24%. And majority of that increase was actually after 2012, so some significant spikes. We know that our young females ages 10 to 14 have some of the highest increase of rates of suicidality, along with our men ages 45 to 64. And then we also know that firearms continue to be the most utilized means for ending life for men, as well as poison for women, females, taking pills and other poisoning means. Our LGBTQIA, so our lesbian, gay, bisexual, transgender, queer, intersex, and asexual youth. Our youth are struggling. They are 4 times more likely to attempt suicide than their straight peers. and nearly half of our transgender youth have had serious thoughts about taking their lives, and a quarter of them have actually made an attempt. So really, truly a high-risk population. And particularly we know that when these youth come from families who are not supportive or who are highly rejecting, that those rates increase significantly. So absolutely important to be aware of, and if you're doing this work in suicide prevention, mental health, understanding your high-risk populations are helpful. Yesterday we talked a little bit about suicidality and screening for this, and how do we screen and offer brief interventions. And someone asked, who are the high-risk populations sort of out there that we know of? This is what research tells us are our highest risk populations. Again, you can see some co-occurrence of identities and experiences on here as well. So what's going on in the world of sexual assault, relationship violence, stalking, and harassment? Well, we know particularly with sexual assault that sexual assault is still a problem in our nation, still a problem absolutely within colleges and universities. We're getting better at assessing it through climate surveys and national surveys, but we know that about 1 in 4 to 5 women will experience sexual assault. Many students experience it their first year of coming to college during their freshman year, and we also know that fall quarter is a particularly high-risk time for students. And we also know, contrary to sort of the stranger myth that's sort of out there, the majority of people who are sexually assaulted know their attacker, and the majority of assaults actually occur within social situations, so parties, social, going out to bars and or after, and a significant number of assaults involve alcohol or other drugs. Again, this co-occurrence of these concerns. So, when we talk about alcohol and sexual assault, we are very intentional, and I think we need to be very intentional, whether we're doing alcohol education or sexual assault prevention and education, understanding and talking about these co-occurring concerns. So up to 75% of sexual assaults involve alcohol consumption. That's either by the victim, by the perpetrator, or by both. Sometimes it's willingly consumed, other times it's being fed to someone, other times there's masking of the amounts of alcohol, but definitely alcohol is the most common date rape drug used. And we have some really interesting research that's come out of the University of Washington, and some of our colleagues and peers have really dove into what's behind perpetrators and sexual assaults, and who's perpetrating these assaults, and sort of what tactics are being used. And we know, again, alcohol is the most commonly used tactic. And we know that perpetrators often utilize alcohol to help facilitate controlling and isolating their victims. They often misinterpret victims' signs as cues of sexual interest, and we're going to talk a little bit about myopia in just a minute and how that sort of distorts perspective. And we also know that perpetrators who utilize alcohol during sexual assaults are more likely to utilize aggression during an assault. But interestingly enough, it's just the amount of physical force needed to actually commit the sexual assault, not gratuitous typically. So typically it's not the knives and the guns that we see in the movies or on TV, but just enough physical force to restrain or incapacitate someone. We know that perpetrators who utilize alcohol often endorse sort of greater hostility towards women in general. They tend to demonstrate less empathy and have higher rates of problematic drinking. And they also have stronger beliefs that women and or victims are more susceptible to assault when they are intoxicated. So again, that utilizing alcohol as a means. So what are our trends around alcohol and mental health? This really, I don't want you to get too lost in the numbers, but this is individuals who are experiencing mental illness with no suicidal ideation. Over here we have individuals with a substance use disorder, but no mental illness. And then in the middle, these 8.2 million, this is where they sort of come together. These are the individuals who struggle both with mental illness as well as a substance use disorder. Pretty significant amount of our population, as you can see. And it's hard to say sort of what comes first. For some individuals, we know that substance use may occur before they have their suicidal thoughts, and that those suicidal thoughts may come as a result of using substances. Other substances may be a result of their attempts to use, substance may be a result of their attempt to use alcohol or drugs to self-medicate. So that sort of, again, like marijuana, trying to sort of self-medicate and manage their mental health. And then other factors could be contributing are things like trauma survivors, being victims of sexual assault, so both having mental mental illness or PTSD, for example, as well as utilizing substance and developing a substance use disorder. So again, a very tangled web, sometimes often hard to know what comes first, but what's most important in the takeaway is to know that these often can co-occur with each other. And we know from a lot of research out there that's really helping us understand these issues that individuals who have higher rates of alcohol consumption are definitely at higher risk for suicide. And both attempts as well as completes of suicides are more likely to occur during heavy episodic drinking. And we know that chronic and excessive alcohol use preceding suicide is highly prevalent. So basically the bottom line, the more alcohol consumed, the higher the risk. So I think this is an incredibly helpful graphic for those of us who are visual learners to really understand when we talk about sort of individuals in the population, adults who have suicidal, all adults who have serious thoughts of suicide, that 3.9%, the blue line there. And we show that past month alcohol use slightly higher. So those who have suicide thoughts, but then also past month, not that high. But when we start looking at past month binge alcohol and past month heavy, so the higher, again, the higher the use of alcohol, the higher the risk. It's pretty significant, definitely statistically significant. So again, really bringing to light and illustrating how much of a compounding and risk factor alcohol can be with suicidality. So unfortunately, for those who are struggling with these co-occurring issues, treatment isn't always often happening. Whether we have about that 8.2 that was in the middle of that previous bubble graph, only about 48% either received mental health care or substance use treatment. So again, in other words, we have about half of adults who have these co-occurring issues receiving neither mental health treatment and or substance use. So a big part of our population, and then when you think about that compounding risk, it's pretty concerning. So what do we do? How do we address these issues? Again, be leery, and I'm sure you all are, of anyone who offers sort of the one trick solution, right? We know from a variety of research, from a variety of literature, learning around alcohol and other drugs, that there is never one solution. As Jason so nicely illustrated before, it's often a comprehensive strategy, and it is absolutely true with these co-occurring issues as well. So in health and wellness at the University of Washington, we've tried to incorporate a variety of strategies, both in terms of our prevention programming and our education and intervention programs. And this is sort of how I like to think about and articulate how these issues tend to co-occur and how we can address these together. So any one thing we do in any one of these areas, we're often calling on and touching upon the other areas, bringing in the research, bringing to life that research, getting it in the hands of our students, and also having very conscious efforts to, when we're doing alcohol education, to talk about sexual assault. When we're doing sexual assault prevention, talking about mental health, talking about alcohol and other drugs. So in the world of our alcohol education, we have screening. Yesterday was truly devoted to, the pre-workshop was around screening and brief interventions. And screening is something I believe in strongly. I am not cover the mic. I'm not a counseling center. We are not a counseling center. But what we do is we do screening because we're able to catch and identify students who may be coming in. Maybe they've been a victim of sexual assault in the past, but maybe they're drinking to cope with their stress. It allows us to sort of catch those co-occurring issues and really tailor our interventions to those students. So screening happens in all of our areas. We provide brief interventions. We also do a lot of education. The work that you've seen Jason do around expectancies, myopia, we're literally delivering that to students. We're putting that in the hands of our students so that they have a better understanding beyond the just don't drink message. We know that doesn't work, so we're very much about risk reduction. And within the world of mental health, again, we're just screening internally, but we also focus on, again, how alcohol, marijuana, trauma history, how all of these things can impact and influence a student's mental health. We definitely offer mindfulness classes. We utilize our motivational interviewing techniques when we're working with students. We have DBT available for students, as well as skill development, working on coping strategies in these various areas. And our bystander, I am a big believer in bystander. Bystander education really started out a lot within the world of sexual assault prevention, intervening in interpersonal violence, sexual assault. Bystander education is incredibly powerful and impactful in all of these areas. So we do a lot of skill development, not just in sort of what you can do in a moment, but also how you can help and intervene with friends. And we definitely, Jason mentioned the Montana Institute and Jeff Linkenbach, who's a huge mentor of mine as well. And I strongly believe, we'll talk a little bit about this in a minute, about positive community norms. And that needs to be an essential component of the work that we do within bystander education, and we'll talk about why. And a community-focused approach. We know bystander training and education that's sort of set within communities, whether that's athletic teams, whether that's like Greek houses, whether that's with social clubs, is so much more impactful because you get the social dynamics involved, and it has a lot more influence and impact. And then healthy relationships, sex, and consent. Again, the work that we do with our prevention work in sexual assault, we'll see in a minute, but we absolutely infuse and talk about alcohol, other drugs, and how this can impact consent, and one's ability to know if they have consent and one's ability to give consent. So this is health and wellness. This is the work that we do. Again, I feel very fortunate, and I'm incredibly passionate about this work, and so excited to be able to bring these fields together and work both in terms of prevention and intervention in one unit. It's a unique model. I'm seeing more and more out there in the country, but we started back in 2009, right at the beginning of the year. And really, I started sort of collecting and bringing. Jason, when he joined our shop, as you can imagine, I was itching to get the research in the hands of all of our providers, really, because not only does it influence those of us providing interventions, but we're able to do evidence-based prevention programming, right? Budgets are tight. There's not a lot of money to be had in higher ed right now if you're a public institution. So I'm a big believer in evidence-based practices as well as being efficient and effective. And we've been very fortunate to partner with our researchers in all of these divisions, and all the trainings and educations we provide are very much influenced and consulting with our researchers around best practices. So when we talk about sexual assault on campus, a lot of people ask us, how do you do this? Like, what's the deal with that? We talk about consent with regards to skill development. Because if you ask students, do you know what consent is? The majority of students today will say, yeah, of course I know what consent is. There's the Consent is Sexy campaigns, there's the Got Consent. But those are sort of, those are great, and I think great at raising awareness. But when we start talking about how do you know if you have consent? What does it sound like? How do you ask for consent? There's sort of this like, what? What do you mean? Like, wait, I gotta say it? Like, what does that mean? So we do the skill, we talk about it in terms of what does it sound like? And then again, reinforcing positive community norms. So I showed you some pretty concerning stats at the beginning, and again, that was just sort of to situate us in what we're dealing with, but I think it never lose sight of the fact that the majority of folks, particularly around interpersonal violence, most people have healthy relationships. The majority of people have healthy sexual encounters. The majority of people, and we know this based on the survey and research we've done, believe in consent and believe consent is important at each step of the way. So if we can push out that messaging and highlight and reinforce the good that people do and the healthy relationships that they have, it helps to not only mitigate those who walk around thinking, well, whatever, it's not that big of a deal, like, so what, I fed them alcohol to be able to have sex. Everyone does that. No, actually, everyone doesn't do that. And the more we can push that messaging out, research shows us the more impact we can have in curbing those behaviors. So it's about partnering with our communities and our students who actually, letting them know that this is an opportunity to really define for yourself who you want to be and who you want to be known as. When we were talking about consent with our students, these are the things we talk about. It's very much an interactive and engaging program that we do, asking them to define consent, talking about the various components of consent. And then we talk about what consent isn't, right? So we'll talk to them about the fact that giving someone alcohol or using substances to lower resistance, that's not cool with consent. Self-centered gratification, so only thinking about your own sexual objectives, not consent. Little to no checking in, not consent. Again, but what we do instead of sort of preaching at them, we elicit from individuals, because it's so much powerful to hear from a group that they don't believe this is consent, and to hear your peers being like, yeah, no, that's not consent, that's not cool. That has so much more impact than someone, 40-something-year-old woman talking to them about what consent is or isn't. We ask, How do you know you have consent? What are the ways that you can ask for consent? We tell them, you know what, if you are a law student, great, and you want a signed contract, awesome, more power to you. But what are the real and practical ways? Because we know that students, we don't want to put words in their mouths. We know that a lot of students do practice consent, and we want them to hear from each other about that. So these are health and wellness. These are things that, again, we hear from our students that they talk about. And then they can also laugh and sort of joke in a very comfortable way we ask, so what are the ineffective ways to get consent? What have you heard around like someone sort of pushing their agenda? And again, it's great because the students will sort of make fun of and laugh at, I want you so bad. You know how much I like this, but we already started. Like they do it with their whiny voices and they laugh about it. But again, what's happening is they're establishing for themselves and their communities, this ain't cool. This is actually not a part of it. So again, so much more powerful than us delivering it for them. So this is one of my favorite exercises that our peer health educators actually do these workshops. They are trained by our staff in health and wellness, and then they go out because the power of peer-to-peer, again, so much different than having someone who is a professional administrator delivering these workshops. They are trained, they take a full quarter class with us, so very much supervised and trained by us, a lot of coaching and debriefing that goes on, but the power of well-trained peer educators is phenomenal, and I'm sure many of you know that as well, but I'm a big fan of our peer education program in health and wellness. But this is such a fun activity because they get into it. Like, so what does it sound like? And like the woot woot, like this is all stuff that they have said, right? And this is amazing. Like you have students who are initially totally uncomfortable and embarrassed and sort of doing their like snickering, to each other. But once we get into it and they get into this exercise, again, it's amazing what they come up with and how engaged they can be. So just to give you Jason has shown you a large part of what we do at the University of Washington with alcohol and other drug education. We are very intentional about the work that we do. We do alcohol skills training, we do basics. Our prevention programs involve a lot of the themes that you've seen Jason touch upon today. And we also have e-checkup available for all of our students. All of the incoming students take e-checkup or through the online orientation program before they even hit campus, and then they also get education once they arrive at campus. And again, this education is very much co-occurring and overlapping. Alcohol myopia is when someone is using alcohol and at a certain point they start to distort sort of the reality of what's going on around them. They start to only focus on sort of what they're really feeling, those most salient internal cues, and they sort of lose track of the external cues. So this can show up obviously when we're talking about sexual assault. Decrease one's ability to process information, less able to detect risk cues, especially if it's not a part of their expectancies. If they didn't walk into this expecting sort of any risky situation, they may not be attuned to sort of these risky things that are going on around them. And not sure about what's happening, how to respond, also can impact our ability even physically to respond. When we talk again about these impelling cues, so if someone is just sort of focused on they're having fun with their friends, they're in the moment, they're completely oblivious to sort of what's going on around them, they may not notice the creeper in the corner, and the creeper in the corner who's intoxicated and utilizing alcohol also may not be completely focused on the fact that actually this person is not into you at all, they're not paying you any attention whatsoever, but they're not tuned into that because all they can see is like, this person's into me. Even if this person is completely avoiding them, it's amazing the role expectancies and myopia can play in these situations. So we talk to our students about that. We want them to understand what's happening. And that, again, when we think about expectancies, is incredibly important to talk about. So I talked a little bit about perpetrators who utilize alcohol. They have certain expectancies of what alcohol will get them and give them. And we also know that someone who's using alcohol may not have the expectancies of being at risk at all. So when we talk about being assaulted by acquaintances or in social situations, unfortunately in our culture we still have a lot of victim blaming that goes on. Like, how could you put yourself in that situation? Why did you go upstairs with that person? Well, if someone is not even in tuned to the risk that's going on around them because they're there having fun with their friend, why would they expect any acquaintance or a friend to be like an unsafe individual? that's not within their realm of what's going on around them. They're not attuned to that. It sort of helps us better understand how these situations tend to unfold, and also helps us articulate in terms of when we're talking to students, both in terms of watching your own behavior as well as looking out for your friends, what could be going on, and why it's so important to have sort of bystander training infused, because if someone's not aware, not able to respond, why it becomes so incredibly important to have your friends, those around you, paying attention to what's going on. So again, with perpetrators, we know that their expectancies, if they are going into a situation with it, expecting to hook up, expecting that inhibitions are going to be lowered, that they're going to be able to get their way, expecting that, of course, why wouldn't anyone be on board with hooking up with me? Like, if this is what's going on in their brain, unfortunately, they may not be attuned to the cues of someone saying, yeah, no, not into it at all, or that silence is not actually, they're not picking up on the fact that this person is not responding. So again, a lot of important work to be done around these issues. And as I talked about, making sure that bystander education, again, I'm a huge, huge fan. And we know that peer influences, particularly when we dive down into social settings, social groups that have some affinity, are incredibly important in shaping behavior. Just a person's ability or decision to intervene in a risky situation is often related to their belief of what others in their social group or immediate environment, if they would support their intervention. And we know this is really true for men in particular. So even if someone holds a belief that, I don't think this is cool and what's going on, I don't like what's happening over there, but I don't think anyone else is really that bothered by it, even if they hold that belief that they don't think that's okay, they're less likely to intervene if they don't think everyone else will be on board and supporting them in their intervention. So again, this is why we focus on bystander training. Again, why we want to do it within cohesive groups who have some affinity relationships, so that they can sort of define expectations for their community. And then once you reinforce that expectation of, yes, not only do the majority of us support that, the majority of us would want to intervene and support someone who would intervene. That becomes incredibly powerful. And we know that we've learned some through research. There's still a lot of research that needs to be done on sexual assault prevention, but we know that working within communities, separating men and women out, or individuals based on gender identity, can be really powerful and impactful. And so again, just being attuned to communities' needs. This is where we start to draw in Lincoln Bach's work around positive community norms. I had talked about why I think positive community norms are so important. So the traditional fear-based education that's out there in a lot of ways, it's designed to scare the health into us, right? Like, if you do this, this is going to happen. Like, ultimate death, So, and it often exaggerates the terrible consequences. It assumes that awareness just of those negative consequences is enough of a deterrent. And again, like we talked about, we know the just say no didn't necessarily work. Even when we were shown, like for those of us of a certain generation, we're shown the eggs frying in the frying pan, and that was your brain on crack. I mean, that's terrifying, right? But if everyone knew that, then why did we have a problem? And awareness of their problems and their risks is critical. We know that it's important, right? We know that we need to be aware of this, but we also know that awareness does not change behavior. It may increase knowledge, it doesn't necessarily change behavior. So what changes behavior? Well, we know that reinforcing the positive, highlighting and drawing upon the good things, the good behaviors, that actually can reinforce and even impact others in making positive health choices. So messaging that portrays health as a norm, as the expected behavior, will result in increased health protections and lower risk. We also know with Dr. Lincoln Bach's work, The Science of the Positive, that it's so much more enlightening and it's a hopeful message, right? And people are just more naturally drawn to hopeful messages. So again, stats will help support the norm, but we also want to clarify any misperceptions. So if there are a group of people who feel like, well, I think that consent is absolutely important and that someone who's incapacitated can't consent. And if we highlight that, illustrate that, then and let them know that, you're not alone in that. And in fact, a lot of research will be done and say, okay, what do you think what do you think the rest of the people think? And if they think the rest of the people are like, yeah, but no one else really believes that, I'm kind of the lone wolf in this, they're less likely to intervene and interact. So again, we want to correct any misperceptions. We want to be inclusive, reflective of the communities, and we also want to let the data do the talking, right? So we don't want to preach too much. We want to just highlight the discrepancies and what research is showing us, and in clear and simple language. So this is a great example of a very effective campaign out of MIT. 97% of MIT students say that they would respect someone who tried to prevent an assault. This is an amazing, overwhelming stat, right? And just the positive community message that goes along with this is incredibly powerful. And our research is showing this is changing behavior. This works, again, when we think about mental health. So, we know a lot of people trying to address the stigma around mental health. A positive way that we can do this is sort of highlighting that 49% of students would encourage a friend to seek help. Only 22% would seek help themselves. 64% say that other people think less of someone who sought treatment. So the majority, only 12% say that they would think less of someone. So again, sometimes the way that the questions are written doesn't allow us to really withdraw on the positive. So we can be mindful when we're flipping the script and trying to elicit the more positive normative behaviors. Trying to address it is flipping it by saying the majority of UW students, 88%, would respect and support a peer for seeking help for mental health. Like, that's such a more empowering message, and also lets folks know that, okay, so breaking down stigma, empowering others to seek treatment, and also empowering peers to support other peers in accessing treatment. So this is for those who are more in the community, just wanting to demonstrate and show how this can be powerful outside of college campuses as well. Again, it's just, instead of focusing on depression, suicide, sort of the negative, scary, really flipping it and saying depression can get better with help. These hopeful messages can be so powerful and really work in our favor, and have been shown, again, through research, to really make a difference in many ways. So at the University of Washington, in the way that we utilize this, we correct norms in our Let's Talk About Mental Health presentation. We also normalize sort of the college experience, what college students typically experience, and then when to be concerned. And we use this, just again, from the American College Health Association, to sort of normalize, you know what, coming to college, it's a transition. It's a whole new experience. And it's okay if you get a little overwhelmed, exhausted. As a matter of fact, the majority of students do. So we want to normalize sort of the college experiences. And we even talk about stresses in terms of, stress isn't necessarily a bad thing. There's actually a little bit of stress can be very motivating and a good thing. Too much stress, that's when we start to become concerned, and where we try to illustrate this in our training and education with our students, is when stress devolves into distress, and when it starts to really impact a student's ability to fully engage with their academics. They start isolating, they start having a hard time functioning, seriously considering suicide. So we're able to sort of normalize healthy norm behavior, and then also illustrate when to be concerned and what to do about it. So we talk about ways to help friends, ways to intervene, again with a motivational interviewing lens, right? So we want to equip our students with how to have these conversations with your friends that you're concerned about. And then, of course, how to make referrals. We want everyone to sort of be able to be those frontline interveners. We don't want to create a bunch of therapists and counselors out there in our students, but we want them to feel confident and equipped to, if they see someone who's struggling, they know what to do and they know how to get them help. So we have a program within Health and Wellness. It's our suicide intervention program. And this is based on Dr. Paul Jaffe's work at the University of Illinois. Basically, anytime we hear about a student who's struggling, whether they're posting things on Facebook, Snapchatting, or saying something or doing something, turning into paper with something concerning, we actually get that information, those reports, if you will, and we reach out to students, and we're very transparent and open and honest about who we are and why we're concerned. And we bring them in and we have a conversation, and we actually have a set of criteria, a threshold, and if a student meets a certain threshold, we enroll them in our suicide intervention program, which gets them connected to support. So this really serves the population of students who are sort of not making it through the doors of health centers and mental health centers. These are the students who are struggling, who may be minimizing their own struggle, or who may just not be connecting, or feeling like, that this is available to them. We utilize this proactive outreach model to reach out to these students and bring them in, have the conversations, and make sure they're getting connected to care, with the ultimate goal of making sure our students aren't slipping through the cracks. And then we coordinate with our health centers, our mental health centers, and make sure that these students are connected and that they actually then receive therapy up to 3 sessions completely free. We have a counseling center that doesn't charge, but they do minimal sessions. But because of our program, we're able to get students in and bumped up the list. So if there's a waiting list, they get in right away, and then access to free care. So again, really important collaborative effort with our community on campus. So the big takeaway, really, again, if there's one thing I want you to take away is that while these are very serious issues and very serious public health issues, they're not insurmountable. There are things we can do. There are positive messaging. There is hope for us. And there are very effective evidence-based ways to address this. I think one of the most effective ways is understanding the co-occurrence and really being responsive and being nimble in the ways that we address and intervene. They are treatable, there is hope available, and raising awareness, having a comprehensive plan, utilizing screening, brief interventions, these are all important tools in our toolkit, and this will ultimately help us increase wellness, safety, and health for not just our students on our college campuses, but truly, I like to say, cradle to career. This is a continuum, and we're all in this together, so absolutely wanting to share with you all what's worked well for us, and hopefully there's something in here that will work well for you all as well. So just again, wrapping up, wanting to say thank you so much. Jason, obviously, such a joy to work with Jason. If anyone hasn't heard of the Montana Institute, I highly recommend it. They do a conference every summer that actually talks about utilizing positive community norms to infuse in the work you do, whether you're a community provider, on a coalition within the community, work on higher ed. It's amazing how powerful positive community norming messaging can be and how that can truly help us all flip the script in terms of public health messaging. So I highly, highly recommend it. And then thank you to everyone in the audience. This has been such an amazing experience. You all are truly professionals in your own right, and I've learned just as much from you all, and hopefully you will have something to take away. So thank you. Thanks so much.